Hello everyone, my topic is infertility. Infertility, or more so called subfertility. So it basically means the inability to conceive even after 1 year of regular unprotected intercourse in the absence of a known pathology. So the peak monthly pregnancy rate is around 30%, and a cumulative rate of 1 year, that means a healthy couple having regular intercourse within 1 year, 85% of the couples will conceive. By 2 years, the rate increases to 95%. Even after 2 years of unexplained infertility, if it is there, then the pregnancy rate drastically drops and it is 1.1% per month. So the total incidence of subfertility is around 10 to 15% in the couples. The causes of subfertility, multiple factors are known. It is broadly divided into female factors and male factors. Female factors contribute to around 2/3 of the causes, and male factors around 1/3. So the female factors would be ovulatory factors, tubal factors, uterine or endometrial factors, endometriosis, and other things. In male factors, it can be from either production, a deformity or dysfunction will be there of the sperm, and even if the sperm production is good, the morphology of the sperms may be hampered, and subnormal semen due to production defects, no sperm due to obstructive defects like absent of vas deferens, vasectomy, coital difficulties, etc. And unexplained causes like ovulation, patent tubes, and normal semen. When all these are there, like there is proper ovulation, the tubes are patent, semen is also normal, even then the couple is not conceiving, then it comes under unexplained, and that can be due to any other generalized disorders. Multiple reasons can be there for unexplained infertility, and that itself is a topic. So coming to the causes of infertility, these percentages are given based on a study which was done in Malaysia, but overall worldwide also these are the most common causes of infertility. Like ovulatory dysfunction contributes to about 46 to 50% of the causes of infertility. Unexplained infertility is around 50 to 20%, not 22, 15 to 20%, and mixed factors about 13%, male infertility about 6%, a tubal factor 5%, cervical factor 3%, and others are 5%. So the important causes here, the most important causes will be dealt with. There are numerous causes for infertility, but the most common and most important ones will be dealt with. First thing, ovulatory dysfunction, tubal problems, endometriosis, male factors, and unexplained. Why these are also important is not just because they are common, also because they are most easily treatable. It's not these are not conditions where there is no chance of conception after you get these problems. So it's easily treatable yet common. Okay, so first and foremost, coming to the history taking. So in history taking, in a female, firstly you'll have to ask her detailed history, coming from age, from where she comes, that is her address, her previous marital history. In the marital history, her sexual history has to be taken into consideration, the coital frequency per week, how many times. So her menstrual cycle, whether the regularity of the menstrual cycle, is it regular, irregular. In the coital history, her coital frequency, associated any dyspareunia if it's there, any profuse pain, because even infection can lead to subfertility, and whether her personal history, whether she smokes, whether she drinks, that history also has to be taken into consideration, and whether she has any other comorbidities. In a male, starting from age, occupation is of utmost importance, and any health issues since childhood, like history of mumps, orchitis during childhood, any varicoceles if it's present, any penile discharge also has to be taken into consideration. And same with coital history, any dyspareunia also has to be tackled. Then whether they are smoking, alcoholic. Occupation is of importance in males, because any usually laborers, usually people working in high heat atmospheres, like high temperature atmospheres, they tend to have a slower production of sperms. Therefore occupation plays an important role when it comes to males. So here basically this graph represents female fertility declining with age, and in contrast to male fertility, actually male fertility, the decline usually starts after 60 years or so, like 55-60 years the male fertility starts to decline, but the female fertility starts declining much before, around 30 to 35 years of age. Therefore the best age of conception, which has the highest fecundity, is around 18 to 24 years for a female, whereas for a male, even 55-year-old man can his sperms, if he has few normal sperms also, there is high chance of conception. So smoking is one personal history, a very important history. Why? Because in women, let it be an active or a passive smoker, it will definitely affect fertility. It will reduce fertility drastically in a woman. In men, yes, it does reduce the semen quality, but the impact is lesser or it is not known. But smoking is hazardous and it is not recommended in a couple who is trying to conceive. In a woman, it is a definite no. So certain types of history which have some relevances, see, first of all you have to elicit in the history itself whether it is a primary or a secondary infertility. So what is primary infertility? Where she has never conceived. Secondary infertility is where she has conceived once or twice, may or may not have led to a successful pregnancy. Say she has had previous abortions, previous ectopic pregnancies, such things have happened, and now she's trying to conceive. It has not happened more than 1 or 2 years, she's trying. Primary infertility is since marriage or since the beginning the patient has not conceived even once, not even abortions. So that is the type of infertility. And the duration of infertility, very important. When a couple comes to you, the first thing you have to prioritize is whether this couple requires treatment based on the duration. Say the couple has been married for 4 years, but they are staying together only for the past 6 months or 7 months because husband was abroad, etc., whatever reason they've been apart, and they're staying for 6 months. So that does not come under treatment criteria for infertility. We should counsel them and encourage them to try for another 1 or 2 years, and even then if they don't conceive, then they require treatment, otherwise not required. So duration and type of infertility, very important. And sexual history, whether there is any loss of libido, any impotence in part of the male, frequency of intercourse, how frequently are they doing. So the normal frequency is around 3 to 4 times per week for a good conception, for a good chance of conception. So if all these are hampered, then it reflects the testosterone level. Any medical history like recent febrile illness, any mumps, orchitis, venereal disease, or renal failure, they all suggest testicular failure or depressed spermatogenesis. In medical history, significantly like liver failure, chemotherapy, or radiotherapy, they all hamper the spermatogenesis. Multiple sclerosis, diabetes mellitus, spinal cord injury, they cause testicular damage and ejaculatory dysfunction. Surgical history, orchidopexy, vasectomies, inguinal hernia repair, all these may cause obstruction and ejaculatory dysfunction. So again, testicular history, like any maldescent of the testis, torsion or trauma of the testis causes testicular damage. Any intake of drugs like cimetidine, spironolactone, GnRH agonists, epileptics, antipsychotics, all these tend to reduce the pituitary gonadotropin secretion and therefore leading to decreased spermatogenesis. Occupational and recreational exposure like pesticides, X-ray, excess heat, radiation, alcohol or drug abuse, they all cause testicular damage. And any other features like anosmia, galacturia, you have to evaluate for a systemic disorder or a generalized syndromes like Kalman syndrome or hyperprolactinemia, any pituitary tumors. So then next, coming to the physical examination. Physical examination in a female, a complete head to toe examination has to be done. More relevantly, you have to see for the body weight. The BMI is very important in the female, slightly important in the male, not very important. Then a generalized examination, added to that a vaginal examination where the uterine size, the mobility of the uterus, any adnexal masses noted in the vaginal examination, and added to that if there is tenderness when you are moving the uterus or when you are moving the cervix in a per vaginal examination, whether the patient is perceiving any tenderness has also need to be elicited. In a male, a physical examination is not always necessary unless and until the female is normal. Normally, we evaluate them simultaneously, and most of the time, the male does not require any evaluation. But otherwise, unless the patient himself has presenting complaints like, say, the testicular size, there is any mass growing in the groins, or any testicular enlargement, etc., has to be evaluated, otherwise not routinely required. So body weight, the importance of body weight is, see, more body fat means more androgens, more adrenal steroids, leading to decreased GnRH production, therefore leading to decreased ovarian hormones, and hence absence of ovulation, finally infertility. Okay, so women with BMI more than 29 are likely to take longer to conceive, and losing weight is likely to increase their chance of conception. So basically, in females who are overweight, with BMI more than 29, 30, morbidly obese more than 35, weight reduction is the first line of management, which is highly effective. It is the most effective line of management, where if there is lifestyle modification, the chances of conception increases by about 20 to 30%. And this is based on studies and literature that just by reducing weight without any medications, the chance of conception increases drastically. So any patient who is having a BMI more than 25, that is, who is overweight, first counseling that we have to give is to reduce the weight. And men also who have a higher BMI, they are also said to have lesser fertility, but it is not proven, but they also will benefit from reducing weight. So women who have a BMI of more than 29 and who are not ovulating should be informed that losing weight is likely to increase their chance of conception. Women who have a BMI of less than 19 and who have irregular menstruation or are not menstruating should be advised that increasing body weight is likely to improve their chance of conception. So, see, when the BMI is less, what happens is they should be in a girl, they should be at least 15 to 20% of body fat to regularly menstruate. So if a woman is too thin also, they will be menstruation problems. She will not be producing the adequate hormones required to stimulate the GnRH, and therefore reduced production. So either way, it is hazardous. So these are some of the testicular problems encountered in the male, which require intervention and treatment. So coming to the basic investigations which we have to send, first and foremost, like I said, the evaluation happens simultaneously for both the husband and the wife. So for the male or for the husband, first and foremost, a semen analysis is sent. So how do you collect the semen analysis sample? It is produced by masturbation, and after 2 to 7 days of sexual abstinence. So in this, so the you have to tell the patient not to have coitus for the previous 2 to 7 days, and then come and give a fresh sample. Do not use any lubrication. 2 to 3 samples may be required, and protect against extreme temperatures. After giving the sample, the testing has to be done within 1 hour. So semen analysis based on the WHO 2000 criteria, the analysis is given as such. Like for a normal report, the volume of the sample should be at least 2 ml. Liquefaction time should be 60 minutes, within 60 minutes. pH should be 7.2 or more. Concentration per ml should be at least 20 million sperms per ml. Motility, at least 50% of them should be actively motile. Total count should be about 40 million per ejaculate or more, 40 to 60 per ejaculate. The morphology, at least 15% of the sperms should have a normal morphology, and WBCs and pus cells should be less than 1 million, and vitality, at least 75% of them should be live or viable sperms. So in 2010, based on certain studies, a new criteria by WHO was given out, which is also called a strict criteria, where if not all the above criteria, at least minimum this much should be fulfilled. So what is the strict criteria? That volume at least 1.5 ml should be there, concentration equal to or more than 15 million per ml. So in the 2000 criteria, 20 million ml or more per ml or more is given. In the strict criteria, at least 15 million if it is there also, the chances of conception are good. Motility, like we saw, 50% or more should be motile. Here in the strict criteria, at least 32%, if they have progressive motility also, the chance of conception will be good. And the normal forms, at least 4% of the sperms should have a normal morphology, whereas in the WHO 2000 criteria, morphology is about 15%. So this is based on a study where people were taken with these parameters and they were evaluated and seen that pregnancy chances were good even in patients who had lesser than the WHO 2000 criteria. Okay. So the semen analysis, if the result of one of the first semen analysis is abnormal, a repeat confirmatory test should be offered. A repeat confirmatory test should ideally be undertaken 3 months after the initial analysis to allow the time for cycle of spermatozoa formation to be completed. However, if gross spermatozoic deficiency or abnormalities are there, then immediate testing can be done. So coming to the female investigations, the investigations to be done in the female, basic investigations are, first and foremost, we need to do a ultrasound, which is the first line. Secondly, we have to send for hormone analysis like mid-luteal progesterone, in case of irregular cycles, FSH and LH, prolactin and thyroxine. And ultrasound ovarian morphology ultrasound will give us an idea about the ovarian morphology. If at all there are regular cycles, then prolactin and thyroxine are not usually indicated. So the first thing is assess the ovulation. See, in a female you have the ovaries, the uterus, the tubes. So first we evaluate the ovaries, then we evaluate the tubes, and the uterus we have an idea, or we will simultaneously be evaluating with an ultrasound. So this is the basic of a female evaluation. Okay, so first thing is, women with regular monthly menstrual cycles are likely to be ovulating. The use of basal body temperature charts to confirm ovulation does not reliably predict ovulation and is not recommended. So to see if there is ovulation, we do a serum progesterone. So in serum progesterone, basically in the second half of the cycle, that is in the secretory phase, the serum progesterone levels will be more. So to diagnose or to detect serum progesterone levels, you have to take it premenstrually, that is at least 5 to 7 days before menstruation. In a patient who has menstruated at a particular date, 20 days after that date you have to take a blood sample to know the serum progesterone level. So in this blood sample, if the serum progesterone is less than 16 nanomoles per liter, it indicates that ovulation has not taken place or will not take place, and therefore you'll have to go ahead with ovulation induction. If at all it is 16 to 30, then it has to be repeated. It is not very indicative of anything. If it is more than 30, likely that ovulation has taken place. 25 to 30 or above, ovulation has taken place. So the next thing we go ahead with is the pelvic ultrasound. And FSH and LH. FSH and LH is usually done on the day 2, and in day 2 samples of FSH and LH, if at all, if it is very high, FSH LH very high, it indicates ovarian failure. That means there is premature ovarian failure, or ovaries are not functioning. That also can be a reason for infertility. And if prolactin is high, then you have to look at any pituitary abnormalities. If thyroxine is TSH is high, then any thyroid abnormalities, the treatment will definitely vary. So coming to the pelvic ultrasound. In pelvic ultrasound, basically a transvaginal ultrasound is done, and preferably a day 2, second day ultrasound is done. So what all do we see in an ultrasound? We have to see the normal outline of the uterus. The tubes are usually not visible in an ultrasound unless there is any lesion, like any hydrosalpinx, ectopic pregnancies, or any tumor in the fallopian tubes. Only then it will be visible. Otherwise it will not be visible on ultrasound. So along with that, you have to see the ovaries. So in the ovaries, we are going to make out the follicles, if there are any follicles that are growing for the next cycle, because this is done on day 2. So for the next cycle, any follicles that are maturing or that are growing, we'll have to evaluate, and that is known as the antral follicle count. The antral follicle count, it will give you an indication of how many follicles are going to mature for the next cycle, out of which one will be super maturing compared to the others, and giving rise to the give rise to the egg or ovulate. So basically, the antral follicle count when done on day 2, it indicates the ovarian reserve. And what is the normal? At least 2 to 8 follicles should be there on day 2. That is normal. If it is less than that, or if it is more than 8, then if it is more, then it may be polycystic ovarian disease. If it is less than that, that means the ovarian reserve of follicles is very low. So in an ultrasound assessment, if more than 12 follicles of 2 to 9 millimeter in diameter is there in at least one ovary, or an increased volume of more than 10 cc, then it indicates PCOD, polycystic ovarian disease. A revised PCOS diagnostic criteria is 2 out of 3, that is oligoovulation or anovulation, clinical or biochemical signs of hyperandrogenism, and exclusion of other etiologies like congenital adrenal hyperplasias, androgen secreting tumors, Cushing's syndrome, and polycystic ovaries on scanning. So either 2 of the 3 criteria, if it is there, then it is diagnostic as PCOD. So the next thing that we have to evaluate is the tubes. PCOD is another separate chapter, not going into the details of it. So coming to the tubal patency. So now, say you have done your ovarian evaluation. The ovaries seem to be normal, progesterone levels are fine, FSH LH levels are fine, prolactin is normal, thyroid is normal, her blood picture is fine. So when all these things are fine, that means she might be normally ovulating. So the next thing we have to evaluate is whether the tubes are patent or not. So what are the tubal patency tests? The tubal patency tests are, first is hysterosalpingogram, which is an X-ray where we inject dye through the cervix or vagina, and we take an X-ray to see if the dye spills out through the tubes. So that is a hysterosalpingogram, like we see over here. Okay, so this is a hysterosalpingogram. In the second picture, as you can see, one side is not clearly, there is no proper spill. Okay, over here, this picture, if you see, on the right and the left side, there is spill through both the tubes. That means this is patent. And over here, Here also both the sides there is minimal spill, so this is patent. Here both the sides there is no block, most likely, I mean there is no spill, so most likely it is a bilateral tubal block. Okay, so the tubal patency tests are HSG, laparoscopy, and dye insertion or chromoperturbation, hysterosalpingo contrast sonography, salpingoscopy or falloposcopy. So this is another picture of hydrosalpinx where you can see the tubes are slightly dilated. Okay, so in an hysterosalpingogram, the false positive results are more because of spasm in proximal ends. Peritubal adhesions are not detected, and 4 to 5% of the pelvic inflammatory diseases occur after hysterosalpingogram. So the results of assessment of tubal factor, the result of semen analysis and assessment of ovulation should be done and should be known before a tubal patency test is performed. And women who are not known to have any comorbidities should also be offered a HSG to screen for tubal occlusion, because it is a reliable test for ruling out tubal occlusion. See, HSG is a non-invasive test, so you can easily perform it. But first, evaluate the husband for semen analysis, and ovarian function should be evaluated. If all this is negative, suppose even if the tubal patency HSG is also normal, ovarian function is also normal, you go ahead with a laparoscopy or a diagnostic lab or a therapeutic lab. So in the next resort is do a laparoscopy and see if there's any uterine pathology, any structural abnormalities, any tuberculosis, endometriosis, any pelvic infection, or any other mass that is present around the uterus, or say in the ovary, in the broad ligament, in the pouch of Douglas, has to be evaluated and treated. So this is more like a diagnostic, and if there is any problem, a therapeutic surgery also. So women who are thought to have comorbidity should be offered laparoscopy and dye, so that laparoscopy and chromoperturbation, so that the tubal and other pelvic pathology can be assessed at the same time. Tubal pathology detected at laparoscopy has a stronger effect on future fertility than that detected at HCG. Why? Because when you detect a tubal pathology in laparoscopy, you are more likely to treat it then and there. Therefore, the chances of conception after that are more. So next is the investigations which are not usually done in clinical practices: anti-sperm antibodies, serum anti-sperm antibodies, postcoital test, sperm function test, any endometrial biopsy. Endometrial biopsy is usually not done. Which are the conditions where we do endometrial biopsy? Like say there's any increased endometrial thickness on ultrasound, or there is an intrauterine polyp, intrauterine fibroid, submucous fibroids, or you're suspecting tuberculosis, then you have to do an endometrial biopsy. Otherwise, not indicated. A hysteroscopy or ultrasound of endometrium, no, ultrasound of endometrium is done. Okay, so this is endometrial biopsy, not usually taken unless and until there are any indications. Next, coming to the hysteroscopy. Hysteroscopy is when there is any intrauterine pathology, like say a polyp or an intrauterine submucosal fibroid or increased endometrial thickness, then we perform a hysteroscopy. Why? Because we focally want to tackle the lesion. By doing a laparoscopy, you're only going to tackle what is in the pelvic cavity, but inside the uterus, a hysteroscopy is the mainstay. And for an endometrial biopsy also, a hysteroscopic guided biopsy is a more better entity, because you are visualizing the focus of endometrial thickness. Otherwise, a blind procedure will not usually give you much result. So ultrasound of the endometrium. Ultrasound of the endometrium is basically done when you want to detect the endometrial changes that happen during the cycle. Like say in the follicular phase, you can see the endometrium. There is nothing visible, nothing much. Okay, whereas in the ovulatory phase, you can see a triple line, you can see a dotted line. That is known as the triple line, where the endometrium is growing and it is receptive. Okay, it is growing itself to become receptive in case fertilization occurs, for the zygote to come and implant in the endometrium. And the third picture you see is of a secretory endometrium, where the it is of maximum thickness. Okay, so if these three normal changes are there in a endometrium, that means the uterine cavity isn't functioning normal, more or less it's normal, and there's no uterine pathology that needs to be tackled with a endometrial biopsy or a hysteroscopy. Okay, so these are your basic investigations which have to be done to evaluate an infertile woman. So coming to the treatment, so starting with a general advice, see, first and foremost, when a couple comes to you saying for infertility, counsel them regarding the chances of infertility, what are the likely causes they might have in in them, to what are the causes that might cause infertility in them particularly, and after evaluating everything, start the treatment on an individual basis. So first and foremost, folic acid can be started for the lady who's trying to conceive. Preconceptionally only folic acid can be started. Folic acid also helps in ovulation to an extent. It helps in the maturation of the ova. So reduce body weight in an obese woman, stop smoking, avoid alcohol, and any other comorbidities, if it is there, then get treated for that, like thyroid, blood pressure, diabetes. Avoid food fads, balanced diet has to be maintained, folic acid and other supplements have to be taken, like multivitamin supplements, calcium can be taken. For a male, stop smoking, avoid alcohol, and men with poor quality sperm advised to wear loose fitting underwear and trousers, and avoid occupational and social situations that might cause testicular hypothermia. So coming to the cause specific treatment, if at all it is an ovulatory cause where the ovaries are not causing any not releasing any ova, then we need to induce it, also known as ovulation induction. So normally in a normal cycle there is development of a single follicle, whereas in ovulation induction there will be development of multiple follicles. Multiple follicles are going to mature at the same time. Okay, so in these patients, see, suppose we do a hormone analysis where FSH and prolactin is done. In cases of hyperprolactinemia, a pituitary cause has to be ruled out, and you can treat it with bromocriptine or cabergoline. Whereas in a patient who has normal FSH, optimize the weight, drugs and surgery can be given. Drugs are nothing but ovulation induction drugs. And if there is increased FSH, ovarian failure is there, so donor eggs. For increased FSH and ovarian failure, there is no treatment. You cannot give treatment for these patients. You have to do an IUI or you have to go for a IVF treatment. So first and foremost, in ovulation induction, weight reduction, and what are the drugs we give? We give clomiphene citrate, the most commonly used drug, gonadotrophin releasing hormone, gonadotrophins like FSH, and insulin sensitizing agents like metformin and letrozole. And surgery is the last resort, that is ovarian drilling is done. So the most common drug that we use is clomiphene citrate, and it is started at the dose of 50 milligrams daily for 5 days, and it can be started between day 2 to day 6 or day 5 to day 9, day 3 to day 7. It depends on each gynecologist, but usually given from day 2 to day 6, because that is where the follicles are maturing or follicles are growing day to day. So that is the time period you tackle the most. And second thing is check for ovulation. So how do you check for ovulation? We check for ovulation from day 10. From day 10 onwards, every day or every alternate day, we have to do a scan to see if the follicles are growing. If there is ovulation, continue the same dose for 3 to 6 cycles. That means in that first cycle, when you have given clomiphene citrate 50 milligrams for 5 days and you are followed up with scan, follicles are growing. The next cycle, at least try with clomiphene citrate for another 3 to 6 cycles, and that is the maximum you can try with clomiphene citrate. Majority of 3 to 6 cycles, not more than that. If there is no response, increase the dose by 50 milligrams. That is the next cycle you give 100 milligrams. After that you give 150 milligrams, and that is the maximum you can give, not more than that. If there is no response to maximum dose, Further increase is not effective and therefore not advisable. So the next, and then if it is not responding with clomiphene citrate, go to the next line of therapy, which is gonadotrophin therapy. In women with PCOD, it is given. It is used to ripen the follicles with repeated doses of FSH, and also stimulate the ovulation with injection of LH or HCG. So the drugs used are normally HMG, which is 75 international units of FSH, 25 to 75 international units of LH is there. Urofolitropin or recombinant FSH is used, or HCG, 1000 to 5000 units of HCG can also be injected. So the next thing, in PCOS, the most commonly used drug along with clomiphene citrate is metformin. Metformin in anovulatory women with PCOD who have not responded to clomiphene citrate and who have a BMI of more than 25 should be offered metformin. They are insulin sensitizers, and it should be given in combination with clomiphene citrate because it increases the ovulation and pregnancy rate. After this, even so you try with clomiphene citrate, with gonadotrophins, FSH, etc. You can try for about 6 to 9 months. After that also it is not happening, then you subject the patient to surgery. In surgery, what you do, we have to do ovarian drilling. That is the PCOS, the ovarian follicles will be ruptured. So women with polycystic ovary syndrome who have not responded to clomiphene citrate should be offered laparoscopic ovarian drilling because it is as effective as gonadotrophin treatment and is not associated with increased risk of multiple pregnancies. So next, coming to the Tubal factors. So in Tubal factors, basically treat the cause. If there is a block, you try and clear the block. And how do you do? By either microsurgical techniques, laparotomy or laparoscopy, it can be done. Adhesiolysis, if there is any adhesions, you release them. Reanastomosis, if there is tubal ligation, or say because of previous ectopic pregnancies, or say failed tubectomies, in such patients reanastomosis can be done, and salpingostomy can be done. The results are not very promising, but an attempt can be made. And usually in a tubal block, it depends whether it is a proximal block, a distal block. If it is a distal block, then there's no use. Usually in vitro fertilization or an embryo transfer is done. Okay. So tubal factors are such that when there is a lesion, when there is a cause, we can just attempt to treat it. There is no guarantee that after doing the surgery, the patient will conceive. Even if she conceives, there are high chances of an ectopic pregnancy. So better with the tubal factors, if there is no scope of surgery, the next best resort is to go for in vitro fertilization or assisted reproductive techniques. So here tubal surgery, like say this is a distal block. Okay, they've shown a picture of the distal block. So in this, salpingostomy is done with laser or diathermy, where the tube is incised and fimbria are created. Okay, this is salpingostomy surgery. Okay, so coming to the male factor. Male factor, again, it depends on the cause. So if at all there is any organic cause, like they say there's a varicocele, there is a previous history of torsion testes, undescended testes, all that have to be tackled and all that have to be treated separately. If at all there is no cause, semen analysis is also normal, even then the patient is not conceiving, then we can give some amount of hormones, like say clomiphene citrate can be given, androgens can be given, testosterone can be given, in order to GnRH hormones can be given to boost up the spermatogenesis. But however, there are no tested trials for this. It is just given and there have been results, but no particular literature is there on it. Okay, so no benefits have been noted. In the absence of any clinical symptoms, the role of antibiotic therapy also is uncertain according to prospective studies and small randomized controlled trials. So the next thing is surgery. Surgery is done in cases of obstructive azoospermia. So appropriate expertise, if available, it should offer a surgical correction of epididymal blockage to improve the fertility. Surgical correction should be considered as an alternative to surgical sperm recovery and in vitro fertilization. So any varicose seals if are present, it has to be corrected. However, it does not improve the pregnancy rate. And the third modality is reproductive techniques. In reproductive techniques, IUI in males, IUI is not usually beneficial unless a total motile sperm count of above 10 million are present. At least 3 or maximum of 6 IUI cycles can be proposed depending on the woman's age. So what is IUI? IUI is nothing but from the male genitalia, we take the sperms, we take the active sperms and inject directly into the female uterine tract. But for this, at least there should be 10 million per ml active motile normal morphology sperms in the male. If semen analysis is abnormal, there is no point of doing IUI because you will not get a good sample. So in such patients, the next resort is either IVF or ICSI. If no pregnancy after IUI, then go in for IVF. So if the total sperm count is less than 10 million, TESA or PESA. What is TESA? It is basically a testicular epididymal sperm aspiration or percutaneous epididymal sperm aspiration if there is azoospermia. In case there is azoospermia, maybe there is some blockage, therefore you directly from the epididymis we can take the sperm aspirate and do an IUI. So coming to the indications for IUI. Indications for IUI, like say in ejaculatory failure, hypospadias, impotence or retrograde ejaculation, vaginismus in the female leading to ejaculatory failure, any cervical factors like say mucus hostility, poor mucus, so the cervical mucus is killing all the sperms, then also we have to go for an IUI. In case of mild to moderate male subfertility or any immunological causes like say male sperm antibodies or female anti-sperm antibodies, if it is there, then also we'll have to go for IUI. Or unexplained infertility. In a female, the indications for IUI can be either ovulatory failure or endometriosis, mild to moderate endometriosis. Severe endometriosis, we have to go for IVF. No IUI in that case. See, for IUI, basically it is just inseminating sperm into the uterine cavity. That means you are only assisting to that extent. The tubes in the female have to be normal. The ovary has to be normal for the ova to get released. The tube has to be normal and the endometrium should be receptive. So in the female, if all those are not normal, doing an IUI is also not going to be very beneficial. So these are the outcomes of treatment for unexplained infertility. Basically, see, in unexplained infertility, IUI does not hold a very good chance because we don't know where the actual problem is. But IVF actually has a better and a good chance. Therefore, in a patient with unexplained infertility, most of them end up in vitro fertilization. So success rates of IUI is it can be as low as 5% or as high as 70%. Usual acceptable clinical pregnancy rate for all etiologies is around 10 to 20%. When combined with a COH in unexplained infertility, cumulative pregnancy rates may approach those of IVF. So this is about infertility, a gist of infertility, I can say. ART and IVF is a separate chapter and requires another class, so that will not be completed in this. But for undergraduate level, this much of infertility is more than enough. Thank you so much.